Wait.
We're good to go.
Wait. We're recording?
We're live.
Okay. Well, good evening, everyone, and welcome to our Group 1 discussion, our nursing committee for DRHA about ethical issues, reflecting to the use of implantable nanochips as a tool for patients with CHF needing ongoing monitoring after discharge from an inpatient setting. Our group members today are myself, Teresa Brumley, Celeste Braley, Todd Gilbert, and Jordan Landrum. I'd like to discuss the scenario brought before us by administration and open up a discussion on the ethical issues associated with the use of this device. The hospital administration has asked this nursing committee. There have been many concerns about CHF patients and home monitoring, a potential for home monitoring, because we've had some readmissions of those patient types. And they would like for us to explore how we can collect data from hospital records, and because there's a potential that they may not have caregivers in the home, and a way to further monitor those by the nursing unit. These patients are frequently readmitted, and this implantation of a device, a nanochip, that records BP and heart rate data and sends it back to the cardiac unit nursing station. They'd like for us to explore this possibility to reduce exacerbations and have an early intervention of those patients that have heart failure. So we're pretty much tasked with, we want to address the following questions. What are the ethical issues that our committee will have to address? Are there HIPAA concerns? And are there environmental issues that may influence our process or decisions? Jordan, would you like to start our discussion and address the first topic on ethical issues?
Certainly. Thank you, Teresa. I did some research over these ethical issues for using both implantable and wearable nanochips to gather our patient data. Simpson 2006 discusses the question of where ethics meets patient information. If the information we gather has the potential to create a situation where patient harm can happen, is it actually worth it to gather that information? At what level of potential or actual harm do we need to make the decision to stop gathering information? And how do we make sure that that information we are gathering is accurate in order to prevent misdiagnosis or harm in that area? So those are a few questions, and then the major ethical questions that come to mind are kind of surround patient safety and patient privacy. The first question that I'm really curious about is, will this technology be in any way harmful to the client? Because as nurses, first, we do no harm. The question is harder to answer than I believe we may think, considering the myriad of ways that information can be used to harm a person. Like I mentioned before, what if the information is inaccurate? If we receive inaccurate information, we will treat the patient based on that information and not what's actually going on. Also, Staggers et al. Discusses studies where nanotechnology has actually made patients more sick because it causes inflammatory processes in the body because it's considered a foreign invader. The next major ethical question that comes to mind for me is, how safe is the patient's information when it is being saved inside the wearable device and in transmission to the hospital? Darwish et al. 2011 discusses the use of what he calls wireless body area networks. These are networks created by devices that we are already carrying that pick up biometric information, such as cell phones, Fitbits, and I mean there are a ton of devices on the market that do this already. The need for tight security on these devices and the transfer of information between devices. For example, when the nanochips would transfer data to the hospital floor, would need to be set up before any patients could have these nanochips assigned to them. In a nutshell, we would need to make sure that our network was secure and the network that the patients were using were secure. So it might actually still involve a visit to facilitate the download, because doing it over a cloud could be a little bit more unsafe for the patient's information. And then the final question will maybe seem off topic a little bit, but it's cost efficiency. I know this doesn't necessarily seem ethical in nature, but I mean, at its heart, it is. Healthcare needs to remain affordable. Is there a lower tech way to gather this information at a lower cost to the patient that will still provide positive outcomes for the readmission rates at the hospital? So kind of just an overview, we will have to make sure that this technology has been first well tested and that the patients receive very thorough and appropriate education on how to use the technology safely, like how to wear the tech and when to wear the tech, or if it's going to be implanted, what to look for signs and symptoms of infection, and how to perform actions that facilitate download of the information to the hospital in a safe manner, that their information doesn't get lost somewhere or sent somewhere that it's not supposed to be. So that information is what I came up with on the ethical discussion of it. And I believe Celeste will continue the discussion concerning HIPAA concerns with that information.
I will go into those HIPAA concerns, but I have a question for you, Jordan, in particular to the harm. You know, I before having this job and working with this committee, I worked in the ICU, and one of the prime things you learn is like ICU 101. You do not treat the monitor or the information, you treat the patient. So when we talk about harm and we're looking at all the data that you present on that's coming off of this nanochip, I think you're right. We have a very real possibility that we're going to treat based on one very small piece of a very large puzzle. So if you're transmitting me blood pressures or you're transmitting information, blood pressures or weight, which could translate into blood volume for you know, a CHF or an overload, that's only one of the things that I need to be looking at in order to determine whether this patient is truly having about to or in of itself an exacerbation. Now I agree, if you've got, you know, if you've got an O2 sat of, you know, 84 and your blood pressure is through the roof and you've seen an elevation in the weight, but not only do you have all of this information, you have individual pieces of this puzzle that you have to think about bringing together. And on the other side of that, you have to have a very solid, knowledgeable clinical person not only evaluating the information and the data that they're seeing, but somebody better be on that phone to that patient to see if what we see is really happening. So I do think the potential for harm is there. The second point I want to make, and is in regards to your point as far as the ethical consideration, Jordan, is the type of patients that this would go in. One of the comments is that these would be placed in patients who had no supervision or no caregiver or no whatever. And I can tell you, in 20 years of nursing experience, that translates to a very low socioeconomic class in my thought process. And I'm not trying to be prejudiced here or put someone in a box, but when you're talking someone who has no support, no family, no caregiver, no money to pay for a caregiver or someone to check on them, then I'm starting to think, okay, then we have a potential for a lower socioeconomic patient to be the one that we're putting this in. And then that opens a whole nother can of worms. Okay, so we do find problems and we're looking at all this information on the computer screen, and then the patient has no transportation to get to the hospital, and then we got to send an ambulance for them, and it turns out the information we saw wasn't really what we saw anyway. So I think those are a couple of my thoughts in regards to harm. And then as far as your third point, and we're talking about money, we are in the business of healthcare, and I think business is the key word. We have to be fiscally responsible. And this is a very expensive technology, one that through my research and looking at this, I don't think this is tried and true yet. And I don't think that we can say that we should use this across the board for all patients, but rather maybe it should be more of a trial phase, or we may should consider this once it's more of a this is working. There's 25 studies, et cetera, et cetera. So that's just a couple of thoughts on what you had talked about.
And
as far as go ahead.
sorry.
I'm sorry.
I just wanted to go ahead and say I totally agree with you. I'm kind of leaning towards the lower socioeconomic status, which is, it's not being prejudiced. It's just recognizing what group you're working in at that point,
Right.
And understanding that like the education is going to have to be really tight on that. And then if we're going to go this route with it, the education is going to have to be tight on both ends. Our staff is going to have to understand and be able to get rid of outliers and data to make sure that we aren't calling these people in for unnecessary reasons. And is it cost prohibitive? Who's going to take the burden of the cost if the patient is unable? So.
Right. The second part of this discussion, not only, I mean, we could probably talk 10 hours on the ethical consideration of this, but I want to talk about the HIPAA privacy. And back in 2008, the U.S. Department of Health and Human Services published their nationwide privacy and security framework for electronic exchange of individually identifiable health information. And the privacy and security rules that were promulgated under HIPAA were the first federal regulations to broadly address the privacy and security of health information. They established the baseline of national privacy and security, but when these regulations were formed, they applied to, when they were formed, they applied to health information in the electronic form. They applied back then. They don't really apply to the current landscape that we have now. I mean, we're talking about something that was just in its infancy stage back when the HIPAA regulations were thought of. So we can't even begin to say, okay, the current HIPAA privacy laws even remotely have the ability to protect patients at this point. I'm looking at this document with me. We're talking about individual access, transparency, data quality, and integrity. Just like you said, the data that's coming across, it starts at point A and then maybe it gets to point B, but are we ensuring that as it's traveling across that the data continues to be it's the same or it's correct? And then the other thing I wanted to mention, I'm sorry here, I had it right here, never fails. An individual choice. So, one thing that it said is that we really want to institute this program for people who don't have the ability or don't have someone to watch over them or a caregiver. And based in this document, it said individuals should be provided a reasonable opportunity and capability to make informed decisions about the collection, use, and disclosure of their individually identifiable health information. And if we're talking about the type of patient that this would be used in, and we talk about the education level and the socioeconomic status, they may not really have a full grasp or understanding of the possible ramifications of allowing us to do this. So that's one thing. And then there's not a whole lot. I mean, this is obviously relatively cutting edge technology, but I did run across a watchdog or a not a watchdog group, excuse me, a leading think tank, and they're called the Foresight Institute, and they're focused on transformative future technologies. And they were founded in 1986, and their mission was to discover and promote the upsides and to help avoid the dangers of nanotechnologies. And what they did say in here, which I found very interesting, it goes back to almost somewhat of your point there, Jordan. It says human implanted microchips may also become a tool of surveillance, since they could be used to track an individual's location and possibly what that person has consumed. So in medicine, as a nurse, one of the things that I worry about is compliance. So we know CHF patients should not be eating at the local fast food restaurants and eating French fries and this, that, and the other. So who's to say that if we're monitoring for CHF and fluid change and this, that, and the other, if we're seeing a trend, then who's to say that this same technology couldn't be used to track the patient and basically police the patient for compliance? So I think that's very concerning to me from a consumer standpoint. It talks about tracking eating habits, smoking, drug use, basically any activity that leaves a chemical trace. So we really could tell you, based on what this group says, that based on the technology, that we really could document what these patients are eating and drinking and doing, and we could come down, you know, potentially they could have some consequences for not behaving like we think they should. So as far as HIPAA, I don't think we have clear-cut rules and regulations in place to protect these patients. So I believe very strongly that the general broad overview of HIPAA policy doesn't cover this. I don't think it covers the transference of the information from the patient to from point A to point B. I don't think that it covers what we can surveil. So do we just watch your weight? Do we watch your blood pressure, or are you going to go and give us unlimited access to what you're doing and how you're managing? So there's got to be some limitations as far as what information is shared. But on the other side of that too, then I must have to ask, as far as privacy protection, how much of that information, if I give you full access and I say, okay, as a patient, that I'm going to allow you full access to my life, then I also have to say what kind of privacy I have about you not confronting me about that. I don't want you policing me. So as far as HIPAA goes, we're not even, in my opinion, based on what I've read, both at the government level and just some thoughts from these different type of groups. I don't think the policies are in place for the general public's protection yet, or not only the public's protection, but we're talking our protection as a facility and providers as well.
Okay. So I kind of had an idea there when you were discussing that. We would definitely need informed consent, almost like before a surgical procedure. If this is something that DRHA wants to go forward with, informed consent would be necessary, and finding out since HIPAA is a big gray area with it, what law is actually protecting the provider and patient, and where do we draw the line of too much information. And that would have to be laid out also in the informed consent, I would assume. Those are excellent points. It's 1984. That's what it reminds me of.
It is a little scary to me as well. Now, Todd, I know you also have some points to make, and I know you've got a question here, and your question talks about the environmental factors that influence and affect the decision.
That's right, Celeste. Thank you very much. Interesting discussion. This is a very broad, very interesting topic. In doing a lot of research on this, I want to discuss the positive and the negative influence when it comes to the issues environmentally. First of all, I want to say that as Catherine Paddock, PhD, stated in her article, Nanotechnology in Medicine, Huge Potential, but What Are the Risks, in 2012, just because material is nano-sized doesn't mean it's dangerous. So there's, like Jordan was saying earlier, there's all kinds of technology currently that we are looking at, and we're looking to expand upon that. In the same article, wait a minute, excuse me, in a different article, Emerging Technologies in Healthcare, Navigating Risk, Evaluating Rewards, it also states that nanotechnology leaves a zero carbon footprint. That was in McGrady, Conger, Landry, and Zucchi, 2010. That's kind of interesting that you know, with the nanotechnology, we're looking at going green in most of the areas in the hospital, and technology would lend itself to that. So to me, that was very interesting as a positive influence on the environment. In the same article, it states that nanotechnology will permit greater patient access from remote settings. As we've already discussed, that's what we're trying to get at, is capture these folks that are not necessarily coming to us when their CHF gets bad. So we're trying to track them where they're at. Instead of them coming to us, we're inevitably going to them, so to speak. And also, this technology promotes a decrease in medical errors and an increase in quality as a result of the technology, McGrady says in his 2010 article. That to me is quite interesting. That we discussed this before with HIPAA compliance and things of that nature, but it kind of makes sense that it's specific to this specific patient, to this specific disease, and we're getting specific information back about that said patient and said disease. So instead of treating folks collaboratively like we do now with CHF, we'll be treating the patient individually, be individualized medicine in regards to nanotechnology, which I think is a very positive influence. Now let's change hats here and let's talk about negative influences. We've already talked about, Jordan talked about the need for equipment to monitor this new technology. There's going to be huge cost involved. We've already discussed that, and that's going to influence how we are going to go about that and monitor that within the hospital. We've already touched on that. In addition to that, in addition to our discussion, we're going to have to specifically train and educate staff to maintain this new technology. So that there'll have to be somebody monitoring this technology on a continual basis, which is going to increase the cost of this. What is already going to be expensive, we're now going to add cost to that as well. We have to provide continual education as well. Just one-time education is not going to be enough. This is too new. This is too vast a topic to hit it once and let it go and see what happens. We have to continually monitor it and re-educate along the way. According to Nanotechnology, the Coming Revolution and its implications for consumers, clinicians, and informatics, there will need to be 24/7, 365 support for both customers and clinicians. Staggers, McCaskey, Braisden, Kennedy in 2008 stated that, which is true. So this isn't a Monday through Friday 8 to 5 situation in technology. We have to continually monitor this, much like we would a cardiac monitor, and that would have to be done remotely. The same article states that it is unknown what the toxicity level of the nanotechnology will be. It is yet to be determined. It is completely undetermined and unknown what the toxicity level will be to a patient. Even if, like you stated, Jordan, earlier, even if it is internal specifically, or even if it's external, we don't know what the toxicity is going to be because we don't have any research to base that on. So in addition to an ethical concern, it's also an environmental issue. And finally, I'd like to mention the roles of the clinicians may be diminished as a result of the technology, which it'll cause unrest among the staff and translate into other problem areas within the organization as a whole. Staggers et al. Said that in 2008 in the above article. You know, anytime you introduce new technology that takes away from the bedside of a clinician treating that patient at the bedside, that's new, uncharted territory for us. That's getting us out of our comfort zone, both as nurses and as physicians and any staff member within the hospital. You're inevitably saying you're putting my job at risk. If I can treat these patients remotely in their own home, there wouldn't be a need for a hospital. So that's a far-reaching, way down the road scenario, but one that you have to think about once you start implementing new technology, as this just with this new technology and nanotechnology. So it's interesting. It's an interesting concept to try to grasp. It's an interesting concept to try to talk about, and you know, I think we've got a good start to it. I think we need to continue to look at this technology in greater detail, because there are things that we just don't know yet, that are unknown, that are still being researched and looked at. And along with that, we need to continually monitor this progress.
Todd, you pulled some very great articles to support both the pros and the cons on both of this, and I almost started to laugh when you were talking about, you know, monitoring 24/7, 365 days a year, because that's what I'm supposed to have when my computer crashes. And you know,
that's absolutely right.
You call
you
IT.
Can't just call China for that, can you?
No, and you call IT, and it takes them 4 hours, and they give you a number, and so my confidence level in the ability for continual monitoring is not here. It's not there that this truly will have a solid set of eyes, and not only a set of eyes, but a competent set of eyes. And
Celeste, yeah, absolutely. Let me add to your thought there that with this technology, what we're trying to do is put the care of the individual back into their own hands. So we have to trust that what they're looking at, they understand as well, because that's what's part of this technology, is they have to be involved with this as much as us as clinicians. So as new as it is to us who are trained, it's even going to be more of a new process to the patient, and you know, putting all of their care back into their hands. When, like you said, what if we can't get a hold of somebody in the middle of the night?
So I'm going to play the devil's advocate and say, if the patient was capable of handling their own care, then we wouldn't be talking about having to do extra monitoring, because they wouldn't get in that situation to start with. So if we're saying we have to really educate them, and they have to, you know, they've really got to be as knowledgeable. If they were that knowledgeable, then they could potentially have the ability not to put themselves in this position to start with. So
I'd like to add,
you're absolutely right.
To this discussion about Jordan's concern about cost effectiveness, and the increased cost to IT support would certainly, you know, salaries for additional IT support. That's, you know, we didn't talk about that, but I'm glad y'all brought that point up. I mean, I know sometimes at night at the urgent care clinic that I manage, we get a recording and a number to call from the help desk, you know, and it's really frustrating when you're in the middle of patient care. So that's a good point.
You also, I think something else that was mentioned, I love that Todd found pros and cons, because something you mentioned was that one article said low carbon footprint, but then another article said we don't yet know the toxins and toxicity that these things can create. With any new technology, there's almost always conflicting information to start with right at the beginning, and maybe this is just too new to institute at this point.
Yeah, I completely agree with you. I completely agree with you.
So,
yeah, go ahead.
I was just going to say, so in review, we have safety and privacy issues related to ethics and such as collecting inaccurate information like artifact or and the patient is potentially mistreated with medications. At the ethical points that Jordan made about a possible inflammatory reaction or infection, even security issues. There's a need for super tight security and making sure that it's well tested. And there are a lot of things that I think need to be well tested. Patients need to be well educated. We don't, as nurses, don't want to. We know we should not just treat a monitor, like Celeste brought up, and I think that's really important to remember that. As far as HIPAA guidelines, the privacy and security rules and guidelines for HIPAA, we kind of feel as a group that those might be outdated in relationship to this newer technology that we have, and that it doesn't apply. They don't have anything available for it to apply. Also, we discussed about individual choice for the patient and informed consent. We have concerns about that this group of patients that are candidates or being targeted for this start of this program are from a lower socioeconomic level of patient population. And we also brought up the potential from some of our reading that there's a potential for policing the patient that's non-compliant, such as smoking or eating improperly or drinking alcohol or just unhealthy lifestyles, and that coming back on them as far as patient privacy. And the environmental issues, those are, you talked about it being good for the environment in general, about leaving a zero carbon footprint, Todd. Hadn't even thought about that. But we all do agree it is an improved way to monitor, but we're not anywhere near there. And I think one of the last concerns that you brought up is about the unknown. There's no information about toxicity levels in patients due to exposure, and yeah, as a nurse, I would certainly want to know more about that if we're promoting something to our patients. So I hope I haven't left anything out, but thank you all for the research that you did, and you guys brought some really great points to this discussion, and I think we'll be prepared to go to administration and show our findings. So,
I agree, Teresa. I agree, Teresa, and I will say that I think that this committee needs to, when we present to the administration, we need to present some alternative solutions to this, such as maybe telehealth. We could talk about telehealth or some other options, or some increased home health visits, or education classes, or something along those lines. I don't think our findings from this committee, I don't think we have the ability to say this is a go as of yet.
Absolutely, I agree.
I agree too. Yeah.
Another option is maybe a CHF clinic that provides one single day a month or every 2 weeks or however much they want to monitor, where patients can come in and have eyes on them, because that's important.
I agree.
So maybe those. I think it's the first time that they've asked us to solve a problem that we're like, I don't know if we want to solve it in this high-tech way yet, because I mean, it could have more issues than it does help. So.
Well, one of the things that they're wanting to monitor is the blood pressure and heart rate with this nano device, but how patient weight in CHF
Yeah.
is one of the indicators when you notice that big influx of weight and water retention and stuff. That's just as, if not more important, for a exacerbation as an indicator for an exacerbation of CHF. So
A scale, a simple scale purchased
yeah.
at, HEB, Walmart, a scale, a blood pressure cuff. I think we have so many more things that could be looked at
Mm-hmm.
before we head down this direction.
Okay. Well, great work, everybody. Thank you for working so hard on this.
Right.
Thank you.
Thank
It's been a
you.
great week. Thanks, guys.
Okay.
Thank you.